Hi, I'm Dr. Cindy Matthews. I'm going to be talking to you today about treating trauma through trauma-focused CBT. Let me share my screen here with you. All right. So I am a licensed professional counselor supervisor in the state of Texas. Just so you know a little about me, I've been a professor at 5 different universities teaching counseling, and I'm currently at Southern Methodist University. I've also been at University of Louisiana Monroe, UNT Dallas, Walden, and Texas A&M Commerce. Just FYI, and I do work with clients who deal with trauma and crisis in the state of Texas. That's where my license is for. So let's talk about what trauma-focused CBT is. It's an evidence-based approach. They've been doing research on it for about 25 years now, and it seems to be effective. Call it evidence-based, and that helps in processing traumatic memories, overcoming problematic behaviors, developing coping skills, and developing healthy interpersonal skills, especially in terms of reconnecting clients with their family and their social support. The major influencers with children and adolescents in particular, it's Doctors Anthony Manarino, Judith Cohen, and Esther Deblinger. They specifically wrote this for children. And Judith Lewis Herman, she wrote the book Trauma and Recovery. Her book specifically talks about survivors of sexual abuse and any kind of abuse, complex trauma, and her 3-stage model is identical to the TF-CBT. So it's a model that can be adapted to children, adolescents, and adults. So trauma-focused CBT takes a variety of different methods. Of course, it's using the cognitive behavioral therapy, looking at thoughts and perceptions and changing unhealthy behaviors and coping. So looking at the whole trifecta there of thoughts, behaviors, coping, and affect. Of course, it's also a very humanistic therapy, and where the relationship really does matter. Creating safety, creating relationship is extremely important. Family therapy is also a part, particularly for working with children and adolescents, is it does a reconnection and interaction with family. With adults, you may do that connection and interaction in interpersonal relationships, intimate relationships, other relationships that are going on for adults. And it also takes into account attachment theory and examines the relationships in there. Also looks at development and neurobiology, what's going on in the brain, but it also considers the age of the child, the adolescent, the adult, and what developmental stages they are in. And trauma impacts different ages differently, as well as culturally and individually. It's also a trauma-informed and trauma-sensitive approach. We'll be talking about some of those pretty quickly. So when we're talking about trauma-informed treatment, we're moving from what's wrong with you to what happened to you. What's the trauma? What happened to you? And how is it impacting you personally? As I said, it's a humanistic approach. So you're definitely going to be building safety, trust, expression of feelings. This is a respectful relationship. There's unconditional positive regard of the client. And it's more egalitarian. It's not hierarchical. So there is respect for what's going on for the client. There's going to be education. It's psychoeducational in nature, with understanding trauma, the implications of trauma, and the treatment goes at the pace of the client, not the pace of the therapist, and they work together in this healing journey. So there is collaboration with the client on the treatment, the skills learned, the pace, the choices, what's going on for them, and conversations that happen. Clients are not pushed beyond what they can handle. It's also a lot about self-care, also for the counselor, but also for the client in terms of regulating emotion, self-soothing, addressing dissociation, looking for what's going on for them and working on what's best for them. There is a connection with family, friends, and support. So it's very collaborative, not only with the counselor, but the interpersonal support that's going on. Together, they help teach and build healthy boundaries and relationships for the client. And they especially focus on empowerment and resilience of the client, post-traumatic growth. This isn't a, you did this, you're messing up, so now you need to do this and you failed. It's, well, you handled this well, and now this is happening. And it's looking at the resilience of what's going on and empowering clients. Right. So I love this graphic when we look at it. So non-trauma informed care, you'll see, is very hierarchical, judgmental. What's wrong with you? I'm helping. There's a right and wrong. You're crazy. Compliance. I'm here to fix you. Egalitarian. Didactic is the counselor telling everything to the client. Didactic is right now me telling you everything and there's no conversation. It would be like the counselor is telling you what to do, people making bad choices, the behavior is viewed as a problem. Whereas if you look at the trauma-informed care, they're talking about the power with the client, not power over the client. So together, your brain is plastic, it's changing. You can change things, neural pathways can be rebuilt, things can happen. People need safety to be able to, safety in relationships in order to be able to move forward. Instead of operating from the dominant culture, which is the white narrative, we're talking about cultural humility, what's happening within different cultures and responses, not just, wow, that was crazy. Oh, well, that makes sense. That makes sense from what's happening to you. So instead of the you're crazy, it makes sense. There's empowerment, collaboration, and empathy based. It's very participatory and respectful. And the goal is connection with self and connection with others in trauma-focused CBT. So the target population for TF-CBT, so those who've experienced trauma and remember being exposed to it. So there's both type 1 and type 2. Herman talks about type 1 and type 2. Type 1 is short-term single incident, and type 2 is complex or repeated. And the theorists are saying that TF-CBT can be used with all of these. It's difficult to use with those who don't remember because there is the narrative piece and talking about the narrative, what happened with the trauma. So that would be very difficult to do TF-CBT if there's repressed memories. Those dealing with the aftermaths of trauma, including depression, substance abuse, PTSD, mood and anxiety disorders, not usually recommended for self-harm, suicidal behaviors. DBT is usually recommended for those. It's for children, adolescents, adults, caregivers of children and adolescents. It was originally for children and adolescents with the TF-CBT, but the adults, like I said, with Trauma Recovery by Judith Herman, works with supporting individuals through the process. So helpful settings, clinical, schools, in-home, foster care, in a variety of different settings. So there's 3 stages that I want to talk about with TF-CBT. Usually about 12 to 25 sessions. I've heard 16 to 20, but it's within that range, sometimes called short term. We used to, now we think of short term as 6 to 8 sessions, but depending on insurance and what's going on for you, it's usually 12 to 25. And it takes into account the development of the client and their pace. So the first one is stabilization of the client from the trauma. So you're focusing on the relationship, you're establishing safety within the relationship and in life and in the office, perceived and real threats. You'll be doing psychoeducation on CBT, you'll be teaching relaxation techniques and affect modulation. So the stabilization stage is all about relationship and psychoeducation. The second part moves towards the trauma narrative. It's the processing of the narrative, remembering, mourning. So you're processing the personal narrative also from a strengths and resiliency focus. So it's not just this happened, this happened, this happened. And you, as a counselor, are becoming aware of perhaps dysfunctional thoughts or thinking that's going on so that you can have those discussions with the client. And you're also helping the client desensitize themselves to the narrative and their thoughts. And with the remembrance and mourning, Herman's particularly talks about this, is you remember the events, but you also mourn, grieve for what did happen and also what might have been. So the sexual abuse happened, you're mourning, grieving that it occurred, but you're also mourning what could have happened if you weren't sexually abused, and that didn't impact your relationships, and that didn't impact your feeling of self and safety. Then the third phase is integration, consolidation. So you're integrating with, if you're children and adolescents, with your family, your loved ones, your support system. For adults, your intimate relationships, family, and then you're consolidating it in vivo, or in terms of in real life. And you're enhancing your overall safety in real life, and you're mastering the trauma support reminders. You are creating a toolbox. And so when you're triggered or things happen, you now have a toolbox that you can go to and help yourself through. So there's the stabilization phase, the trauma narrative phase, and the integration consolidation phase. Some people like this little practice acronym, I guess, is that phase one, you're doing psychoeducation. And for those who have children, you're also teaching parenting skills. You're teaching relaxation, affect expression, modulation, and cognitive coping. So that's the prac. The T is the trauma narrative. And phase three is in vivo mastery in real life, conjoint sessions with loved ones, with parents, and enhancing safety and future development. That's helping with the toolbox in case of triggers. So some people like that. You may not, up to you. So let's talk about stage one. And you've got to remember that this is a triphasic model. It's got the 3 stages, but it's not linear. When you see things are happening with the client at their own pace, you can go back and forth, back and forth. The first part you should be really good at as a beginning counseling student, or even midway through. It's establishing safety in the relationships. You're doing that person-centered kind of conversation. You're reflecting, you're restating, you're building the relationship during this initial interview. You're listening, you're being present, you're validating, you're normalizing. So during the intake interview, you're going to educate them about TF-CBT. You're going to educate them about trauma, the impact, the effects of trauma, and just kind of get a general feel for what's going on for them, not the whole narrative, just what's happening to them. And you're establishing trust and safety in the relationship, also in the counseling room, and looking at how you can help them feel safe and comfortable together. You could do some initial assessments. I know the ACEs is a really good one with children. The child behavior checklist, PTSD, trauma checklist that you can be looking at, the Beck depression inventory, the Beck anxiety inventory, the Beck suicidal inventory, also good. There's also a PTSD screening, DSM-5. So you're getting a feel for what's going on for the client. The most important thing is that you are helping them feel safe and comfortable in the environment with you. So focus on real and perceived threats in session and outside. What can you do to help them feel safe? And of course, if there's any kind of threat of harm to the individual, suicidal threat for themselves or for children, if they're being harmed, you need to take the necessary precautions at that point to be able to inform authorities. You're also going to be doing homework assignments with family members and supportive individuals. That could be watching movies, that could be drawing, that could be having a conversation. There's lots of things, practicing relaxation, so you get them ready for the whole process. So when we're talking about psychoeducation with what TF-CBT, as you move along to the next kind of steps, the first step is really just a general education, getting ready for the process and doing some assessments. That may take a couple sessions depending on the client. You're also going to be learning processes. So if you're familiar with CBT, of course, the ABC model of the activating event, belief, consequences, you'll be doing cognitive restructuring and cognitive processing as it comes. and affect modulation. However, one of the key core elements is teaching relaxation, teaching self-regulation. When somebody's, we always use the SUD scale when I work with my clients, SUDS, systematic units of distress, 1 to 10. And 1 is not feeling distressed, 10 is highly distressed. And so whenever, and when they come in, we'll talk about how they're doing, and we'll give a number 1 to 10, and we'll do some relaxation to bring them down to like a 2 or 3, or 1 would be ideal. And if ever they move above 5 or 6, we're going to do some of these relaxation techniques to bring them back to a place where they feel comfortable. So some of the relaxation techniques, skills that you'll be teaching them before you've even gone to their narrative, before you've had these conversations about what happened and working through the cognitive piece, is self-regulation. So you're helping regulate the distress. So they may come in, they say they're at an 8. So you have them picture in their mind. So this self-regulation, picture in their mind a peaceful image, and just kind of help walk them through. What do you see? What do you hear? Guided imagery kinds of things. And then, so you teach them when they have a distressing thought, or it starts to kind of feel like I'm moving my SUD scale up to a 7, that you have them work back from that spot. Okay, go back to that place. What do you hear? What do you see? What do you feel? What do you smell as you're in that place? So you practice with them moving from a higher score to a lower score, and you spend as much time as you need in that spot, in that space, to be able to move down. You can do relaxation breathing, of course. With children, you can pretend that they have a balloon in their stomach and they blow it up and then blow it out and then blow it up in their stomach, like they have a balloon in there, and blow it out. Count of 4. With adults, you can do the same thing. Have them place their hands on the diaphragm and do about 4 or 5 breaths. That's a great way to bring them down. Also, modeling as a counselor is really important, that you model doing these skills with them, the breathing, the self-regulation skills, so that you are keeping yourself at a lower SUD score as well. So some grounding skills, you'll teach them how to ground themselves. So if you find them disassociating, so you could say, okay, right now, say your client's name is John or Jill. Okay, Jill, I want you to tell me right now 3 things that you can hear. Okay, 2 things that you can see. Okay, 1 thing that you can feel. So you want to bring them back to the present state. Progressive muscle relaxation from the toes to the head and back again. That's the kind of thing of, okay, think of your toes, have them close their eyes, breathe, think of their toes, and then have them tighten their toes super tight for about 5 seconds, and then relax them. And then do the same thing with their ankles, make them very tight, and then relax them. And then do that all the way up their body and back down, just to bring them to a place of relaxation. And this is really good to teach them the skills. So as you work through the narrative and you start to see that they're getting distressed, you can bring back the ones that feel most comfortable for them, that they relate to. And each person will have their favorites. So try to get 2 or 3 good relaxation techniques that can help them, that work with them. Another thing is called anchoring. So again, you imagine a picture from their history or their imagination that's safe, such as the beach. So you flash back to that safe place, again, the guided imagery. And then you anchor it with an item such as a stone or a necklace that they hold on to. And so every time, so you carry the stone or item and squeeze it when anxious, and when anxious, to help them become comfortable. So like when you're teaching them the imagery, they have, like if you have some of those really pretty stones in your office, you can have them, as they're doing the imagery, squeeze the stone. So every time they squeeze the stone, they think of that place and visualize it, And so anchor themselves every time in that. I know when I did it, when I was going through my master's program, I had a counselor do it with a necklace. And so every time I felt stressed, I would grab onto my necklace. I would anchor myself with those self-soothing thoughts, the image, and some different comfortable thoughts that would help bring down my SUD score. Also, you want to work with clients they may come in somewhat okay. You're going to talk about a lot of hard stuff, which is going to distress them, and you want to bring them at the end. And it's kind of more like up and down, but if at the end you want to leave them feeling relaxed and comfortable. So you'll do some of this stuff with them at the end, especially. But if they're still feeling distressed, one of the things that you can have them do is draw or write out what's distressing them, put it in an envelope, staple it, and say, okay, this is for therapy here and now. I'm going to keep it safe here and now. And we're going to talk about this next time. So just keeping this as the safe place to have the discussion. I want you to wait until you can come back next time to do that. So you're teaching them lots of relaxation. There's a lot of different techniques that you can work with. Of course, mindfulness meditation. Meditation works for about 80% of people. So you can have them practice meditation or mindfulness, but be careful that it's not a panacea for everyone. It works for some, but don't be upset with your client if that doesn't work for them. Biofeedback, there are some packages via Amazon or wherever that you can have them connect their fingers with and measure their heart rate, their skin temperature, and their breathing rate, to teach them to relax themselves. Some pretty inexpensive ones that you can get that way. Progressive relaxation, that's the tensing and relaxing of muscles I was talking about. Exercise is a really great way that can lead to increased relaxation. Guided imagery. Try not to use in guided imagery your favorite space. Go to their favorite space, wherever that might be. It might be their bedroom, their grandmother's living room, it might be a forest, it might be a beach, but help them visualize their safe space. And also the deep breathing, deep and slow breathing. And you can practice and teach them how to do that as well. The shallow breathing is going to make them more uptight. So you teach them to breathe deeper in their diaphragm with their hands on their diaphragm. So after you've taught them about relaxation, you also want to talk about cognitive distortions and cognitive restructuring. This isn't specifically using theirs yet, but just kind of the process. You want to teach the ABC model, that there's an activating event. There are some beliefs and there are some consequences. And you look at how their thoughts and their emotions and their behaviors all interact. And you talk about that, and talk about that's also a place where you can make changes. So you teach the ABC model. Beck and Ellis talk about dysfunctional thinking patterns. And I think Beck came up with 8. This is just a nice little graphic that I use with my clients about unhelpful or dysfunctional thinking. Adler talks about it, mistaken beliefs, but you're talking about all or nothing thinking, overgeneralizing, mental filters we use, how we disqualify the positive, jumping to conclusions, magnifying emotional reasoning, shoulds and musts and labelings and personalization. And the reason you're doing this is you're teaching these patterns so that you're getting ready for the narrative. So when you do the narrative, you'll be able to notice these and have discussions about what's going on in their narrative, in their head, that they're playing it back in a certain way. So you're teaching cognitive distortions, you're teaching restructuring, the ABC, and how you can dispute and make new thoughts and new beliefs. You're also going to be teaching affect modulation. And that's, for kids, it may be labeling emotions. It might be helping them recognize and realize emotions. So they may have an emotions journal. where they learn about emotions and what's going on for them. So once they learn about them, then they can start regulating and figuring out what's going on for them. Also with adults, you may be also teaching emotions, especially people who have addictions. They have stuffed their emotions away with whatever addiction that they have. So you may have to be teaching emotion at the same time. So you're going to so you're going to teach about affect and feelings and expressions, and teach affect modulation skills as well. So you help them become aware. You might identify and label with them, help them understand, accept what's going on for them, readiness to confront the emotion, possibly modify it, and getting support for themselves, and just trusting what's going on for them. What are some targets for change in their emotions? How can they regulate it? And of course, when you are regulating or changing, you again are going to be doing muscle relaxation, breathing relaxation, non-judgmental awareness of what's going on, accepting it, being compassionate with self of what the emotion is, analyzing and modifying. So you're going to be doing this process with them of teaching them about affect, and the feelings and expressions, being aware of it and help them modulate it. But at the same time, you're also talking about how the cognitions are affecting the affect, which are affecting the behaviors. It's just not by itself. It is a trifecta of cognitions and affect and behavior, and the triangle of all three impacting each other. So if you get a little confused about the CBT kinds of information, there's a lot of good online resources. And now this is just for CBT, not the TF-CBT. So therapistaid.com has a lot of relaxation exercises, especially for children. They have some for adults too, but it's really, really helpful. Grounding techniques, deep breathing. You can, as you're teaching it, you could have a handout, give it to them so that they can practice it that week. That's the homework kind of thing, coping with anxiety, worry, practicing mindfulness. There's also a relaxation skills guide, therapistaid.com/therapy-guide relaxation skills guide. There's a lot of really good resources that are free on this website. Psychologytools.com also has a lot of good worksheets, handouts, and audio packs. One of the handouts earlier on the dysfunctional patterns of thinking, that was from Psychology Tools. CBT worksheets is at CBT Psychology Worksheets. Just Google that and you'll be able to find that. livingcbt.com. And also specifically for training for TF-CBT, there's the tfcbt.org training, which is $2.99, and tfcbt.musc.edu, which is $30. And there is a TF-CBT workbook, which teaches a lot of these schools as well. If you Google TF-CBT workbook final PDF, you'll be able to find that. But there's a lot of really good homework assignments and resources that you can use to teach all those skills I was just talking about with relaxation, cognitions, and affect modulation. You can be going and labeling emotions and all that kind of stuff. So you don't feel like you have to do it on your own. So that's the first stage. The first stage is all about establishing safety in the relationship, teaching about TF-CBT, teaching about CBT, how that works, and relaxation, and teaching the skills ready to move on to part two. So part two, I want to talk just for a second about the brain. I'm sure you know all about this, but this is the reason we move into the narrative. When trauma occurs, it does not process immediately, does not store in the prefrontal cortex. So you've got the prefrontal cortex that does the thinking and logic. Trauma stores in the limbic system. So it goes to the amygdala, which has the fight, flight, fawn, freeze kind of stuff going on, which doesn't have a lot of verbal stuff going on, and the hippocampus, which regulates memory and emotions. So it's strongly placed in the back here. But what we're trying to do with the narrative, and it's kind of just all in pieces scattered, it's not in any chronological order, it's just a lot of stuff, which is why we may get triggered by stuff, is because we haven't put it in a formulated narrative. So what we do is we take all of this and move it to a narrative that we can process from the amygdala, from the hippocampus, and move it with thinking and logic and learning skills. That's really simplified, but it's a quick overview process. Interesting thing is when we're talking about the hippocampus and the amygdala, especially, it's not in the verbal form, it's more kind of in pieces of memory. So stage 2, we are going to start the narrative. We go very slowly. And it's also a remembrance and mourning and grieving. So it's retelling the story of the traumatic event and mourning the loss. But your job as the counselor is to keep the brakes on. Don't go too fast. You create the narrative. You can do it through art, bibliotherapy, psychodrama, Sandre. We'll talk about those in a second. And you start the process. You can start with little traumas and just kind of teach the process, help them feel safe and secure, and then we can move to larger narratives. So some steps to help recreate is you think of something that happened last week that was perhaps a little traumatic. So perhaps you got in a fender bender car accident. So you think of the beginning and the end. So the beginning is you perceive a threat is going to happen, and the end you realize you're going to survive. And then you practice working through this timeline with them, 6 stages or however many, until that they can get familiar with the process, trust you, so you can do the larger narrative. And you as the therapist are going to be telling back the story as accurately as possible. And I'll show you that in just a second. But you're also using relaxation throughout. So remember I talked about the SUD scale, systematic units of distress, 0 or 1 to 10. Where are they? Anytime you're checking with them, where are you at as you're telling the story? Do some relaxation with them to bring them back to a 1 or 2. What you're trying to do is have them become desensitized to the event. You're also going to be cognitively processing it. You're going to be highlighting their strengths and their resilience. Oh, what helped you think of that? You did survive. What were things that helped you get through that? But you also help them mourn of what did happen and what might have happened. And you use psychoeducation tools as possible. And always at the end of a session, you're discussing their reactions, you're counting backwards hundreds by sevens, you're telling them to go do aerobic exercise afterwards because it can be pretty stressful. You do relaxation, you do kind of things to take them away from the traumatic memory to move them back to their cognitive processing. So hundreds by 7 backwards, that's going to move them here, out of the amygdala and the limbic system and the hippocampus. You move back to the prefrontal cortex. But always tell them to go do aerobic exercise so that they can get their body moving, getting endorphins going, oxytocin, go hug, whatever it is, moving that along. So here's 3 different ways that you can work telling a narrative. So for example, there's a graphic timeline. At the beginning, so for example, here's a car accident, car wreck. At the beginning, you see the Nissan car who's going to hit you. You recognize and realize there's a threat. You feel the impact. The car flips or skids or something, and you realize you're upside down. You unbuckle the seatbelts. You wait with somebody. This person in this one, surgeon stopped and waited with them, held their hand. The EMTs came and they recognized that they were going to be okay. So actually writing a graphic timeline, the beginning when you start to feel the threat and to the end. And this is a process that you help them. And you see the halfway point, make sure you're always checking, make sure they're breathing, relaxing, and being able to tell it in becoming more and more relaxed. The written narrative, you could have them do a 5-minute writing of the first half, intermission, let's do a relaxation, diaphragmatic breathing, and then 5 minutes to write the second half of the graphic timeline. And while they're writing, just prompts, keep your body relaxed. With a relaxed body, take 2 more minutes. So you're using that relaxed tone and reminding them, okay, just take a moment and breathe. And especially if you see them getting stressed. You can also have them pictorially draw, and you can do this with adults, children, whatever, of the whole thing. And you could do these 3 during a session, and then pictorially taking that and then telling you the story, and then you repeating it back and having them correct anything. But you're listening non-judgmentally. And with you doing that 4 different times, they have told the story in one session, just a simple one, just to get safety, just to get them used to the process. 4 different times, they're becoming desensitized to the story and the trauma and relaxing throughout it. You're teaching them throughout this process of this 50-minute session, perhaps an hour, whatever you set aside, so that they can become desensitized to the trauma of their story. And then you're going to do things like that with the larger traumas and with what else has happened. So you help them work through it. So when you're exploring the narrative, there's a lot of different ways to explore it. Remember I said it's back in the amygdala and the hippocampus there in the memories, and it's mostly in images. So you don't want to just do talk therapy. You want to use interventions to explore that work for them. Get trained in them, of course, but use a medium of their choice to explore the narrative. In the TF-CBT workbook for children, there's lots of drawing. If that's something that works for them, great. But there's a lot of other expressive arts that might be helpful. So for example, sand tray therapy, I highly recommend that. I use that with adults all the time, of having a sand tray and figurines, and they recreate parts. And then I don't say, well, tell me why you did this, but tell me how you would label this sand tray. And I notice that you have someone in the middle who has a gate around them. Talk to me about that. Talk to me about this. And you're processing images and what's going on, and they are starting to pull things together. You could use psychodrama, which is actually very fun to do and a fun way to get trained. If you are in the Dallas area, Katrina Hart, I think her company is called Bridging Heart. She does a lot of training with that, and that's a fun way. I know there's some online training for that, where they act out different pieces of themselves. There's dance therapy, music therapy, bringing music that speaks to them. This works really well with adolescents, I've found, is that they bring music that speaks to how they're feeling or what's going on for them. Starting the conversation, I've had clients write music, write songs, sing them to me, and that's been really awesome. Of course, you can also do some bibliotherapy with books, talking about books or movies or shows that work with them. I've also heard people using anime, Dungeons and Dragons, different ways of being able to explore and work through. I strongly recommend you get trained in anything you use so it doesn't get out of your control. Play and activity therapy for children and youth, of course, creation of a book. TF-CBT for children highly recommends that they create their own book, with paper and stapled, so that it becomes a narrative that they can tell. So lots of different ways to explore. So during the process, as they're starting to tell the story, as they're bringing it together, you're starting as the therapist to process what's happening. You want to be able to look, as they're telling it, look at the cognitive distortions. Start to notice them. Don't immediately come in and pound them. I noticed this, I noticed this. It's you notice them, you might want to write them down and bring them up. You also want to contextualize their traumatic experience in a larger framework of life. For example, date rape in the context of a rape culture or of a university or of a fraternity. You want to contextualize the trauma occurring in the larger society, the larger framework. So racial trauma, for example, in a society that's extremely highly racist, with dominant culture, a lot of things happen, and it's not the person's or victim's fault that it happened, that it is contextual and it's taking blame and victimhood away from the victim. You know, they have been traumatized, but it's not their fault. And when you're a victim, you often feel like it's your fault. So you're taking away the fault and the blaming. So helping understand that what's happened to you is the problem, not you, the problem. You want to include, as you're going through it, always be aware of their thoughts, their feelings, the body sensations, what's going on for you right now in your shoulders, what's going on for you in your breathing, how are you feeling right now, where are you feeling this? So help them be aware and claim that. You're using relaxation tools throughout. And again, you're helping the client become desensitized to their narrative, but also at the same time, creating a narrative that they may not have had. And you may be rewriting the narrative because they may have put it in a certain context where it's like, wow, when I understand this, then I get this. You normalize the feelings, the emotions of the client, and you reinforce their bag of coping skills or their toolbox, whatever you want to call it, whatever metaphor. And you're also mourning and grieving for what did happen and what might have been. So a lot of these kinds of tool bag things are teaching coping skills, reframing, where their sources of strength. How did you get through this? That may be a strength. Awareness of cognitive distortions, what's going on, how am I looking at this? You're empowering them, helping them breathe. So you're creating tools for them through this whole process of the narrative. You taught them skills at the beginning, more focused on you. In the middle, part two, it's more on them. Here's the narrative, but here's ways of looking at it. Here's ways of strengthening yourself. Here's ways seeing yourself in context and processing and putting the whole narrative together. And then so you're moving from the counselor stage 1, client stage 2, and stage 3, we are going to move to integrating into the world and in their family. So it's kind of moving counselor, client, integration with family. So you're moving with the narrative to, if there's a perceived threat or a trigger, you're teaching them to relax, use their skills to a desensitization. So for example, that's the perceived threat of a spider. You teach them to relax, and then, a spider becomes their friend. Wouldn't happen for me, but sure, we'll go with a spider or a snake, whatever. Okay. So stage 3 is about reconnecting the individual and helping them with post-traumatic growth. And this can be happening throughout. Remember, it's not a linear model, but you're helping them reconnect and sharing the narrative in a safe and supportive environment. You may be working with individuals through this process and bringing parents or a loved one in throughout the process for different pieces of the narrative. You may be teaching these support people some of these skills, especially with children, so you can help reinforce like relaxation or grounding or anchoring out in the outside world, because that's the whole thing, is you want to move this to the outside world in vivo. So you want to connect to the present and the future, and the post-traumatic growth, reconnect with the self. What am I thinking? What am I feeling? Connecting with the body. I'm feeling this tightness in my stomach. What's going on? Help them become aware of what is happening in their body and not to dismiss it. People who have been traumatized tend to dismiss what's happening to them because they go to their fight, flight, freeze, or fawn, and they dismiss themselves. They're protecting themselves, but they dismiss these. And so it's like, hey, that's a red flag. I need to relax here so that I can recognize the red flag. This may be a time I need to get out of here. Or you know what, this may not be a safe person. I need to go away. So help them connect with their body, their thoughts and feelings, so that they don't stay in uncomfortable feelings or places or with uncomfortable people, that they learn to respect what's going on in their body and their thoughts and feelings, and find support. So perceived threat, and then they move to relaxed body, comfortable body, intentional instead of reactive behaviors. And that's where we're really moving towards as we become more aware of what's happening within us, is that we become intentional instead of reactive, and post-traumatic growth. So have the client share their narrative with their caregiver, move from sharing it, well, they need to share it with themselves to you, to a parent or support person, and encourage support individuals to reassure and support the client throughout the story. So you may be bringing them in and out, like I said. Reinforce the safety of the client, look for red flags, trust inner voice, and reinforce the tools that they have learned. So one of the things from Judith Herman, I know this looks very a lot on the screen, but Judith Herman is really talking about, as an overview of TF-CBT, and also Cohen and all the others, is stage 1, educate, stabilize, safety. It's all about the relationship. Stage 2, process the narrative, remember, mourn. And you can pause me here so you can read through this. You're going to use cognitive approaches, affective approaches, and behavioral approaches to help them work within the narrative. You're going to reprocess and look at cognitive distortions. And stage 3, you're reconnecting with individuals, with family, intimate relationships, and you're going in vivo, in real life, to be able to do this. And you're helping clients move from reactive to intentional. That's what we're doing with stage 3. Not a linear model, remember. You can go back and forth, back and forth. And remember, the whole time through stage 2, you're always going back to those relaxation techniques, and you can use those in stage 3, of course, as well. So a quick critique is it benefits. It's evidence-based, 25 years of use with positive results. It goes at the pace of client. It helps with cognitive behavioral issues and reduces stress of client. It improves supportive interactions with family. And it is effective with physical abuse, exposure to domestic violence, traumatic grief, PTSD, and sexual abuse. TF-CBT is not for problems and issues not related to trauma. It is not effective for runaway individuals, suicidal or cutting behavior, self-harm, and is also not helpful for resistant clients. And also, like I said, it's not helpful for people who don't remember the trauma. It does take 12 to 25 sessions. EMDR may take 1 or 2 sessions or 3, so that may be shorter. I actually like to use EMDR in conjunction with TF-CBT, and I use mindfulness and DBT as well. I use combination. So according to the research literature, TF-CBT is effective for type 1 single event and type 2 multiple and complex trauma experiences, and for those willing and able to engage in the process. There's a bunch of references, and that's it for TF-CBT. Thanks for listening.